Hey everyone, welcome back to my channel. I'm Sheila G, the PAC, and today we're taking a deep dive into polycystic ovary syndrome, or PCOS, and how it affects the skin. Of course, don't forget to like, comment, and subscribe to my channel for all things dermatology. Let's get started. So the skin really acts as a window into the body to reveal so much information about our overall health, possible systemic diseases, and hormonal imbalances. I tell patients all the time that the skin is such an important endocrine organ, as most, if not all, endocrinopathies or hormone-related issues have some sort of influence on our skin and therefore signs that can be seen on the skin. So let's talk about the most common endocrinopathy in females of reproductive age, which is polycystic ovary syndrome, or PCOS, and how it affects the skin and overall health. Simply put, PCOS is a condition where the ovaries produce too many androgen hormones, which prevent ovulation, and it is the leading cause of anovulatory infertility in women. So to dive a little deeper, let's first go over the phases of the menstrual cycle and what hormones contribute in order to get a better understanding of what happens in PCOS. The hypothalamus in the brain normally releases a hormone called gonadotropin-releasing hormone, or GnRH, in a pulsatile fashion. GnRH acts on the anterior pituitary gland and tells it to produce luteinizing hormone, or LH, and follicle-stimulating hormone, FSH, which they act directly on the follicles in the ovary. So there are two primary cells located on ovarian follicles called theca cells and granulosa cells. During the follicular phase of menstruation, the steady flow of LH acts on the theca cells, where cholesterol is converted to progesterone, and then progesterone is converted to androgen hormones. Meanwhile, FSH is acting on granulosa cells to convert progesterone into estrogen, and so the developing follicles are preparing for ovulation. Then a dominant follicle forms, which contains the egg that will be released during ovulation. Ovulation actually occurs due to a surge in that LH hormone, which then releases the egg. This is when the luteal phase of the menstrual cycle begins. During the luteal phase, the empty follicle, now called the corpus luteum, produces progesterone to prepare the uterus for pregnancy. This increase in progesterone tells the hypothalamus to again regulate the levels of LH and FSH. Now in PCOS, it is believed that the hypothalamus produces GnRH in rapid pulses, leading to a higher amount of LH being produced compared to FSH. We don't know exactly why that happens, but a genetic predisposition has been suggested, as we have seen a hereditary pattern. So this higher amount of LH stimulates the theca cells to produce excessive androgen hormones, and that is the key to most of the problems in PCOS. We call that hyperandrogenism. So when I say androgen hormones, I'm referring to male sex hormones such as testosterone. Women naturally do produce these hormones, but here it is excessive. So because FSH is relatively lower than LH, there is a lack of follicular maturity, meaning a dominant follicle does not form. And so then we're left with these multiple immature follicles present on the ovaries. And that's actually what can be seen on an ultrasound, and it gives the appearance of cysts on the ovaries, hence the name polycystic ovary syndrome. Because that dominant follicle does not form, ovulation then cannot take place. And because ovulation doesn't take place, there's no surge in progesterone to go back and tell the hypothalamus to regulate GnRH and therefore regulate LH and FSH again. So essentially, the increase in androgen hormones being produced by the theca cells throws off the whole cycle. And in addition to this, not only are the theca cells producing androgens because of the high amounts of LH, but so are the adrenal glands. Now, to make matters even worse, insulin, which is a hormone produced by the pancreas, also stimulates those theca and adrenal cells to produce more androgens. So this high amount of androgens, what that can do, it creates insulin resistance. Because now there's insulin resistance, it tells the pancreas, just keep on producing more insulin. And so this just creates a vicious cycle and further complicates the issue. Hyperandrogenism and insulin resistance can present with various signs on the skin, but please note that just because someone has one or more of these signs doesn't necessarily mean that they have a diagnosis of PCOS. There is a whole criteria that has to be met in order to make that formal diagnosis. Now let's go over the actual skin findings and possible health complications. One of the more apparent skin findings of PCOS is acne. So our oil glands or sebaceous glands naturally have androgen receptors. And so when androgen receptors bind to these oil glands, there's a higher amount of oil production, and the skin cells along the oil gland itself just become more sticky. And so therefore we have more clogging of the pore. So those who have PCOS tend to have more stubborn inflammatory acne, and we tend to see it more commonly on the lower half of the face, so the jawline, the chin, and we can see it on the neck, the chest, and the back. Now, just to be clear, all acne is driven by androgen hormones. So I always reiterate to patients that in most cases, those who have acne actually have normal androgen levels. It's really more so a matter of how sensitive the oil glands are to those hormones, and that can be a genetic thing. But here in PCOS, we know that there are excessive androgen hormones, and so therefore acne is quite common. Also, because there is an increase in oil production due to the high amounts of androgen hormones, those with PCOS are more likely to develop seborrheic dermatitis. Now, sebderm is a condition where a normal yeast that's already living on our skin feeds off of that high oil production, and so then we can see flaking and some redness, usually along the T-zone, so around the nose, the eyebrows, some people can get it under the ears, and then also the scalp causing dandruff. And then there is hirsutism, which is excessive hair growth in a male-like pattern. So similar to the oil glands, the hair follicles also have androgen receptors. When androgens are high and act on those receptors, it may turn the small vellus hairs or peach fuzz hairs on the face, neck, chest, and back into thick terminal hairs as seen in men. And that occurs in about 60% of women who have PCOS. Now, for those who have insulin resistance, it can cause a change in the skin known as acanthosis nigricans. And that's where we see these kind of thickened dark plaques, usually on the neck, behind the neck, under the arms, and sometimes in the groin area. We may also see an increased amount of skin tags in these areas as well. Those who have PCOS are more likely to experience weight gain, increased glucose levels in the blood, and ultimately they're at higher risk of developing type 2 diabetes and cardiovascular issues. Another condition that can be seen in those with PCOS, especially those who are overweight or obese, is hidradenitis suppurativa, or HS. Now, HS is a chronic inflammatory condition involving the formation of cysts and abscesses in folded areas of the skin. Now, most of the time, this is an entirely separate chronic condition of its own, but those who have PCOS are more likely to develop it. So I have an entire in-depth video all about HS here on my channel. Due to the imbalance of hormones, women with PCOS often struggle with irregular periods and difficulty conceiving due to anovulation. But those with PCOS can still conceive with the right management. Now, there is no cure for PCOS, but the treatments are really targeted at managing the symptoms and improving fertility. As far as treatments for PCOS, weight loss itself can actually restore ovulation in about 80% of women who struggle with the condition. But it's important to note that not everybody who has PCOS is overweight. Other treatments include oral contraceptives, metformin, aromatase inhibitors to improve fertility, and anti-androgen treatments. But what treatment is chosen really depends on whether or not the patient wants to conceive or not. A common anti-androgen treatment that we employ in the dermatological setting is oral spironolactone, which cannot be used if trying to conceive. Spironolactone was originally a blood pressure medication, but it has anti-androgen effects on the oil glands and the hair follicles, therefore improving acne, hair loss, and reducing hirsutism. PCOS is very challenging, it's multifactorial, and involves a vicious cycle of hormonal imbalances, so the best treatment typically involves combination therapy. So there you have it, the pathophysiology of PCOS and how it may present on the skin. I will be making an in-depth video all about spironolactone and its applications in dermatology very soon. Thank you guys so much for watching, and of course don't forget to like, comment, and subscribe to my channel for all things dermatology. I'll see you next time.